Good afternoon, everyone, and welcome back to the afternoon session of our One Health Symposium. This is a part of our day where we invite our community, our faculty, staff, and students to join our One Health Cafe, where community partners and distinguished guests will have the opportunity for an intimate kind of like a one-on-one discussion. And today we're going to focus on the topic of ethics and vaccinations in an effort to reduce the information gap between the vaccinated and vaccinated, and also to address some of the polarizing statements that are beginning to occur in not only the media, but also in more sacred spaces about the two different populations. Today, we have to lead us in this powerful discussion, our very own Dr. Rueben Warren, who is currently the director of the National Center for Bioethics and Research in Healthcare and professor of bioethics at Tuskegee University. He is also the former director of the Institute of Faith Health Leadership and adjunct professor of public health, medicine, and ethics at the Interdenominational Theological Center in Atlanta, Georgia. From 1988 to 1997, Dr. Warren served as the Associate Director for Minority Health at the Centers for Disease Control and Prevention. And from 1997 to 2004, he was Associate Director for Urban Affairs at the Agency for Toxic Substances and Disease Registry. Dr. Warren also served part-time as the Director of the Infrastructure Development for the National Center on Minority Health and Health Disparities at the National Institutes of Health in Bethesda from 2005 to 2007. And from 2004 to 2009, he was on leave from the National Center for Environmental Health at CDC ATSDR, where he served as the Associate Director for Environmental Justice. As the Associate Director at ATSDR and CDC, he led the agency responsibility for environmental justice and minority health. And of course, we know while he's here with us at Tuskegee University, he has led and also authored many different publications on the discourse between public health ethics, research ethics, and ethics and research in healthcare. We also have joining us this evening, Dr. T.S. Harvey, who's an associate professor of medical and linguistic anthropology in the Department of Anthropology, Center for Latin American Studies at Vanderbilt University. With training in medical and linguistic anthropology, Dr. Harvey's research and interest focus expanding scientific partnerships, developing innovative technologies, and building local capacities to collaborate tactical large-scale global public health and environmental challenges that emerge at the critical intersection of vulnerable populations, health disparities, disease risks, environmental degradation, water, sanitation, and infrastructure. The evolution of this transdisciplinary approach is the product of over a decade of funded collaborative research, capacity building work, and global engagement on a wide range of topics that include, but are not limited to, cross-cultural doctoral patient communication, language and culture in global public health, waterborne diseases, enteric illnesses, disaster prevention and relief, neighborhood approaches to risk reduction, crisis management, sustainability, resilience, and environmental protection. I'll stop there and turn it over to our very capable moderator, Dr. Rueben Warren.
Good afternoon. It is both an honor and a pleasure to be a part of this conversation. I caught a little bit of this morning's session, and I will catch more of it tomorrow, but it was really exciting to see the cross-disciplinary, transdisciplinary, institutional and disciplinary boundaries that are being broken. The notion of One Health. I first learned about One Health many years ago from our own Professor Emeritus, Dean Emeritus, Walter Bowie. He talked about that. See, I'm a dentist, and I've had to fight years and years from words like doctors and dentists and doctors and dentists. So Dean Bowie helped me to understand that we're all in the same thing together. So whether you have a MD, a DVM, DDS, PhD, JD, Doctor of Science, all of those, that's part of the mix. That's part of the conversation. So we don't want to make any of us the other. So our conversation today is about not being the other. In the context of this symposium, of this empowering session, I want you to think about a new language, because everybody thinks that they have their own ethics, and in fact they do. But as you engage in your work, how often have you heard issues around right and wrong, good and bad? In my context, I've always heard about statistically significant. I've heard about variance, but I've not heard about the rightness and wrongness. So give me just a moment to give you a context, just a short moment, about what we're going to be talking about and listening to today. What is ethics? Everybody has their ethics, they say, but ethics is really a new language for many of us who are not in that field. Ethics, from my context and the work that we do here at Tuskegee, is a set of rules, principles, values, and ideals of a particular group of people, the systematic study of morals, concepts, theories, typically in departments of philosophy. We've had to grow out of the departments of philosophy to talk about the rightness and wrongness of things. And as you listen to our speaker this afternoon, think about the context from which you hear right and wrong, whose context is right and whose context is wrong. As we're engaging in this One Health notion, I want you to also to consider the notion of bioethics, which grew out of the framework of ethics. Bioethics, from our context, is an applied ethics focused on the doctor-patient relationship and how it changes in the healthcare delivery system and how it affects it. Prime example is the Affordable Care Act. Some argued it was an economic issue. Others argued it was an access issue. I would argue it's an ethical issue that deals with research and healthcare delivery. Now, in that context, I've learned from many of my veterinary colleagues that the grounding in public health really started in School of Veterinary Medicine. In dental school, I didn't learn much about population health. In medical school, I don't suspect my colleagues did either. But the whole notion of herd immunity came out of veterinary context. So we talk about population health. Let's talk about that in the context of what we're going to hear this afternoon. Lastly, you've heard the word health disparities. That's an ethical construct. It is the systematic, potentially avoidable differences in health or in the major social determinants of health between groups of people who have different relative positions in the social hierarchies according to wealth, power, or prestige. Health is determined by your wealth, your power, and prestige. That's an ethical framework that I hope we'll hear more about as this conference goes on. And we've worked for many years, I have, in the whole area of health disparities, and now we've shifted to health equity. But I would suggest health equity is ideally that everyone should have a fair opportunity to attain their full potential, and more pragmatically, that no one should be disadvantaged from achieving this full potential if it can be avoided. And when I teach this subject, a student once reminded me, he said, "Doc, it's not if it can be avoided. It really is, it must be avoided." So I've reframed my thinking about health equity. It is a construct that must be avoided. It must be avoided. You have to achieve health equity. Let me close my comments by contexting what I hope to hear this afternoon. Let's shift the paradigm from benevolence, which is the intention to do good, to beneficence, which is doing good. Listen carefully to what's actually going on that's really doing good, not theoretically benevolence, the intention, but the actual doing good. And hopefully we will achieve health equity and optimal health as we move forward. Again, I'm so pleased to be a part of this conversation. Look forward to our afternoon presentation. Thank you, ma'am.
Thank you, Dr. Warren. And next we'll have, I'll bring forward Dr. Harvey and get his presentation up for his comments.
Thank you so much for the introduction. I'm delighted and honored to be here, to be able to have an opportunity to have this discussion. So what I'd like to do is just to talk a little bit about this work. And thank you, Dr. Warren, for your words, because I think they really articulate precisely what this is all about, and hopefully some of what I'm able to talk about. So I want to talk about an approach to thinking about health equity, and an approach to thinking about inequalities in healthcare. So my perspective here is from the view of medical and linguistic anthropology. So that means a couple of things. One of the things it means is that I'm interested in, at a micro level, the interactions between healthcare practitioners and patients, not just in the United States, but my research is abroad, but also health communication beyond the doctor-patient communication at the what I call the meso level, at the public health level. And then one level up for that, thinking about the role of medical communication in managing global public health, things like pandemics and epidemics. So this work moves through the micro to the meso to the macro. And I want to talk about specifically the micro interactions that contribute to some of the macro systemic inequalities that we see. And in the case of my research that I'll be presenting today, vaccine hesitancy. So I want us to take a common framework, which is thinking about public health in terms of upstream, midstream, and downstream. And I want us to think about the upstream specifically here in terms of historical atrocities, and to think through that in terms of how that plays out in micro interactions. So how histories of medical atrocities and clinical coercion can induce vulnerabilities and increase risk. So again, thinking about this as historical, as upstream, we think about how some current vulnerabilities, specifically in the case of COVID-19 pandemic, are vulnerabilities that are induced by past histories. Next slide, please. So just a little background. I mean, I work in Central America, but I also work in other places. But today I'll be talking about my research in Central America, and this has to do specifically with vaccines. And I think it is an important sort of way to think about vaccines in a contemporary context, though this research was done a number of years ago. So it's the Western Highlands. Just for those who are not familiar with the region, there are 23 different indigenous languages that are spoken here in addition to Spanish. So one of the issues of understanding practitioner-patient interactions and health outcomes is to understand the cultural and linguistic dynamic that exists here. And to do that, of course, you have to work within the languages. So this research was conducted in the indigenous language Quiche, which is the largest spoken indigenous language in Guatemala. Next slide. So I just want to talk very briefly, this is not a class on this, but I want to talk very briefly about design and why a linguistic anthropological approach is important. So when we talk about, for example, vaccine, specifically issues of vaccines in Guatemala, of course, we can't think about that without thinking about Dr. Cutler and what happened in Guatemala in the 1940s, what the historian Reverby brought to light having to do with the US government actually being involved in a study that really it was happening at the same time as the infamous Tuskegee study in the case of Guatemala. They were actually using prostitutes to infect inmates and to infect the mentally ill. And in addition to that, they were also injecting. So this is the historical backdrop. But if we want to think about how this sort of reverberates into the future, we want to think about vaccine coercion in a clinical context. Again, following Dr. Warren's lead, we're thinking about clinical interactions. So how does this actually operate? So as a linguist, I was interested in recording clinical interactions to see precisely how macro policies got translated on a micro level. So one of the things that has consistently happened in Central America is there are often mandates that come from North America and elsewhere having to do with global health standards for vaccination coverage. So during the time of this research was conducted, which was in the early 2000s, the idea was that Central American countries in particular had to show enough vaccination coverage in order to warrant certain funding. So the way that was achieved, again, so that's a macro decision about vaccination coverage in an attempt to reach millennial goals that had impacts at a micro level. So what my research was interested in looking at, in part, was precisely how did they go about vaccinating the public? How did this happen? Not just in thinking about campaigns broadly, but how did it actually happen in clinical encounters? So that is the linguistic framework to actually see what are the communicative and cultural practices that produce this. So we're looking at recordings of doctor-patient interactions. I collected and recorded hundreds of these. So the approach is to medical communication. It is discourse analysis. It looked at speech acts. It looked at communicative events. Again, all of this very micro stuff. But again, the idea is to tie it to what was happening at a macro level. Next slide, please. So one of the things we need to recognize in terms of, again, taking up on Dr. Warren's comments, the idea of doing what's right. So in the case of Central America, I'm speaking about Central America specifically, there needs to be a recognition that global health is actually Western biomedicine. So when we talk about global health, we're not often talking about a plurality of different types of health, different medical modalities that grow up in other countries. Specifically, what we're talking about is the exportation of biomedicine globally. So in this process, as I'm talking about this again on a micro level and a macro level, I want to talk about something that in my research I call biomedical manifest destiny. So this was, of course, manifest destiny was the doctrine used by the United States to justify the expansion of the United States from the East Coast to the West Coast. And of course, we know the implication of that for indigenous peoples. So what I argue is that a lot of global health, sadly, has become really focused on biomedical manifest destiny, which is a sense that what the West does is inherently necessary, that this project is inherently benevolent, and that it is a noble enterprise. This is the argument, right? So the question is, with those sets of predispositions and presuppositions, how then does something like the deployment of vaccine mandates happen on the ground? How do they go from these multinational decisions about the need for vaccination coverage, which we agree on, and how it actually gets implemented on the ground? Next slide, please. So one of the things the doctor-patient encounter involves, because another one of my lines of my research has to do with doctor-patient interaction. So part of what the exportation of biomedicine globally depends on is the existence of a universal patient. But the argument that I have made in my research is that patients are not born, they are made. A patient is a Western category that presupposes a certain set of ideas. And the exportation of this idea of the patient assumes that wherever biomedicine goes, be it Central America, be it Africa, be it India, it will find patients. And of course, the research shows that that's not exactly the case. We learn to be patients in the same way that physicians learn to be doctors. It's not natural. So what happens when there is the expectation that there are patients where there are no patients? So oftentimes what happens is that these populations, as my colleague at UC Berkeley, Charles Briggs, has written, are often referred to as unsanitary subjects, people who are somehow outside of biomedicine, unwilling to comply. At least this is how they are constructed. So part of my research talks about what the expectations of the patient role is in order to unpack what is the culture of biomedicine, right? So part of being a patient is this presupposition of a doctor-patient relationship involving two people. It is the presupposition that patients will be compliant, that they will respond to sound healthcare advice. The idea that the body is the primary site of treatment, that would be the source of illness and affliction. The idea that suffering should be avoided. All of this seems quite natural, but as the research demonstrates, the notion of the patient itself is Western and something that we export. So what happens when populations, there's this sort of cultural contact between Western biomedicine, global public health, and populations where you don't have patients? Well, what you get is a reading of local behavior as somehow resistant to biomedicine. The need to, in many cases, the need to disabuse local populations of the ideas that we often see as somehow in the way of health. Next slide, please. So again, going back to this vaccination campaign, I want to talk specifically about medical manipulation. So there was this history, of course, of these experiments in Guatemala dating to the 1940s. And as a result of that, there was tremendous resistance to vaccines in general. But that tide had begun to turn around the time I did my research, early 2000s. But a lot of that attitudes towards vaccination was sort of changed with the revelation by the historian Reverby about these atrocities that happened in Guatemala, sort of setting things back. So I want to talk specifically, again, going from the macro to the micro, how did these ideas about vaccination coverage actually get deployed? So one was the idea of vaccination campaigns, and they very explicitly defined this as an attempt to get to the quote unquote medically unreached with the consistent narratives of saving the children. So I want to give a few ethnographic examples of how this worked, right? So the primary mechanism was this idea that without a vaccination card, you could not have a consultation. So people showed up for consultations unrelated to vaccination, and they were consistently denied a consultation unless they had been vaccinated. Oftentimes, the majority of the time, they did not have their vaccination cards, and as a result of that, they were vaccinated repeatedly for the same thing. So this is sort of how it operated in a clinical encounter, but it didn't stop there, right? The idea was there still were a lot of people at the time, again, early 2000s, who didn't want their children to be vaccinated. So as an anthropologist and a researcher, we wanted to find out what were the bases of their unwillingness to vaccinate their children. Of course, there were multiple answers, but I want to give you one concrete example. Again, thinking about upstream, midstream, and downstream. So in an effort to get the vaccination coverage, in order to demonstrate that Guatemala, in fact, had the coverage that it needed in order to secure funds, as well as other things, at one point, the federal government and local leaders agreed that children would be vaccinated. So what they did in the village where I worked is that the folks came in to vaccinate the kids, but they didn't tell them they were going to be vaccinated because they knew that if the parents knew, they wouldn't show up. Why? Because of the history of medical atrocities. So what did the teachers do? They allowed the folks to come in and to vaccinate the children. As they came into the classrooms, they locked the people into the classrooms with the health professionals with the children. They herded them up and they forcibly vaccinated them one by one. So these were the stories that we got over and over again in the village that helped to explain contemporary resistance. But it didn't stop there. It continued on, right? So these are just some examples, right? So one was this clinical coercion, right? No vaccination card, no consultation. The other one was this medical outreach, again, with the presupposition that this is for their own good, but again, not really acknowledging their choice or decision here and forcibly vaccinating children. So next slide. So as I wrap up here, I want to sort of give a story about this, which is an ironic story and rather haunting. So this image on the left-hand side is an image of quote unquote Zip Coon. There's a song associated with this that most people know, even if they don't know, they know it. So in the United States, and as it turns out in Central America, the song that ice cream trucks play is the tune to Oh Zip Coon. So again, thinking about medical missions and neocolonialism, biomedical neocolonialism, there was an attempt to reach the unreached. So in the background, there's an image of the kind of terrain that's in this village. So we were working at one of these hilltops when I saw, to my great relief, these coolers coming up the side of the hill. And I was elated thinking that we were all going to have ice cream. And I explained to the people who were in the community that we were going to have ice cream because that's how people got ice cream out to the rural areas. They asked me to be quiet and to listen, and I did. And they said, "Do you hear that?" I said, "Hear what?" They said, "There's no song." So because there's no song, that's not ice cream. Those are vaccines, okay? So the vaccines made their way up the hill, right? Again, the context here is all that I've already talked about. Kids having just weeks before being forcibly vaccinated, right? So what this made for was a confrontation, a physical confrontation, right? So I guess part of what we need to think about, of course, is the history of these medical atrocities, how they play out at a meso level, which in this case is a public health level, but at a micro level. My research details the way in which patients entered these clinical encounters and were encouraged, specifically doing using strategies like tag questions, encouraged, coerced to agree to these vaccinations. And all of this, of course, right, serves as the backdrop now as we think about COVID-19 and we think about vaccines. All of this stuff doesn't go away. What I argue is that all of this becomes a vulnerability, a kind of iatrogenic vulnerability induced and produced by histories distant and near, that then come to inform the kind of decisions that people make about vaccines, whether or not they want to take it. So these are upstream things that really have downstream impacts on decision making. The lived experience and the lived history of a people having to do with clinical coercion and medical atrocities actually is becoming a determinant of health, not just in the United States, but also in Central America. So if we are to redetermine the determinants of health, we have to engage these issues head on and not debate whether or not, not make this about some sort of hesitancy or make this about the people themselves, but to think about the process that got us to this current situation. So at that, I'm going to wrap up, but I'm happy to, of course, have conversations and engage further. Thank you.
Thank you very much, Dr. Harvey, for those comments. And I'll turn it over to Dr. Warren for any response. And then we can go to our questions.
Okay, Dr. Harvey, that was an excellent presentation, and it had me thinking about, was I in Guatemala or was I in the United States, 1940, 1950? It's very confusing. And what must be clear is that the same physicians, the same agency that engaged the United States Public Health Service syphilis study at Tuskegee, the same docs who were in Guatemala. So that's something, that's the context, and I think our communities understand that. I think we ought to appreciate and respect that understanding. Let me invite any questions that may come to Dr. Harvey. I know you're full of them. I have a pocket full, but I want to let others have their choice. Please.
Hello, can you hear me?
Yes.
This is Bill Grizzle. I find this extremely interesting, given our current issues. I think one of the problems that we have in getting people into the yes vaccination group is that we're not very straightforward in actually the complications that are occurring in vaccination. Like today, we heard the head of public health say essentially that somewhere between 5 and 15% of patients with COVID in hospitals actually were fully vaccinated, but he didn't discuss those 5 to 10%. And I think that sort of secrecy in its way actually puts people in the anti-vaccination camp. And we'd be much better off being much more open as to what the problems that were occurring. That's my comment.
Excellent comment. Any thoughts about that response to Dr. Grizzle comment or Dr. Harvey?
Yeah, so thank you for the comment. I think that's very important. So as somebody who focuses on the language of public health, what I could tell you is that no ambiguity goes unused. So unfortunately, anything that is not clarified, that ambiguity becomes a space for imagination. So quantitatively, there's always more misinformation than accurate information, and the same goes for disinformation. So what happens is that oftentimes ambiguity or a lack of clarity is exploited for, in some cases, political means, in some cases, it's not intentional. But the idea here would be to kind of think about the ways in which the risk communication has operated in this pandemic, the failures and successes of risk communication, the kind of one-size-fits-all policies that we've taken, which is inconsistent with what we know about risk communication and public health needing to be targeted, right? That the group of hesitant and unvaccinated are, they're complex, they're not monolithic. So all of this, of course, requires us to think very critically about the messaging. But as I said, the other piece is to not underestimate what the public role is in determining the significance of this. That ambiguity is never just simply left as ambiguous.
Another question.
There's one question in the chat, Dr.
Yes.
Warren. Okay.
Yes, I was going to read that. Question to Dr. Harvey. Can we discuss use of terms like anti-vax and those who aren't interested in COVID vaccines right now doesn't make them anti-vax? Excellent question.
Right.
Harvey?
Yes, this is a very good question, and it's very observant. So it goes back to what I just said about the monolith, right? So the monolith is a very convenient way to think about how to communicate risk. However, in this case, what you actually wind up doing is reaffirming a lot of the kind of concerns that people have. So in lumping these groups together, what you do in essence is you acknowledge a lack of understanding of the complexity of the situation, right? So as I said, there are historical reasons in some cases why folks don't want to get vaccinated. Some of those reasons have to do with obviously information, but this is not entirely about information. So one of the things we learned early on that was a kind of naivete of public health was this idea that somehow if you got people enough information, that would solve the issue. But this is not entirely about communication. This is about other sets of ideas and perceptions of coercion, notions of freedom, all of these sorts of ideas that are deeply embedded in the culture of the United States. And I would say as a researcher that a lot of this has not caught us by surprise. A lot of this is actually quite predictable and quite expected. The other piece that I just like to mention here, it has to do with something that I've been working on, which is this notion of bioprivilege, right? This idea that some folks have the right to deny vaccines historically and others don't. So bioprivilege here suggests that, again, following the notion of the neoliberal subject, is that somehow if you possess this bioprivilege, you get to make your own decisions, and that gets, of course, constructed as notions of freedom. And this is also very much a part of this. But I think what we need to recognize historically is that bioprivilege is not something that we've all been privileged with, and that there's certain folks who've enjoyed it and certain populations and others who have not. So we're seeing a number of different threads reaching into and out of this. And the complexity of it really demands that we don't really just paint this group, anti-vaxxers versus hesitant with a broad brush. And of course, there are many other categories.
One colleague asked, what is a patient and what is a not patient? Dr. Harvey?
Okay, very good question. So I wrote a paper called Where There Is No Patient. So one of the things I tell people in the United States is I say, raise your hand if you were born in a hospital. And a lot of people at that point raise their hand. And what I say jokingly is, congratulations, you're a patient. So in this case, right, a patient is a set of comportment practices. So the other example I like to do, because I give continual medical education credits in hospitals and clinics. And one of the things I like to say is just to make the familiar strange, because the patient is a familiar thing. One of the things I like to point out is that it is one of the few roles, the roles of health practitioners that exist on the planet, whereby within a few minutes, a perfect stranger can ask you to remove your clothing. And a patient is expected to do that. So the point here, right, is that if that sounds natural, then we're patients. But what I've seen internationally is that the expectation that someone should treat someone in the capacity of a healthcare provider is somehow absent in the presence of the white coat is not universal. So a patient is someone who understands the expectations. A patient is someone who understands that what a medical interview is and that they're supposed to respond in a particular way. Someone who seeks care, someone who is receptive to medical recommendations. All of these things constitute patienthood. And what we realize is that this is not international. There are people who look very strangely upon the very idea that they would remove their clothing. Again, I'm giving a simple example in front of a perfect stranger. The very idea that they would disclose the most intimate details of their life to a perfect stranger. But if that doesn't sound strange to us, it's simply because we've learned what that role is, what the expectations are. So part of what I've written about is that competency means not that practitioners learn everything they need to know about some other culture, But in part, what we do is we teach people what the culture of biomedicine is. Sorry, that was a lengthy response to an elegant question. Thank you for that.
But so quite appropriate. And in that regard, another colleague says, well, what is the ethical responsibility that healthcare providers have in facilitating patient compliance, particularly to public health preventive measures?
Right. So this is a complicated question, and it's different for different people, right? So for healthcare providers, obviously there's a different set of expectations with regard to ethics. But I can say, as an anthropologist working in the space of public health, my job was not to encourage people to do anything. My job was to figure out where the gaps in information was and to make sure that people understood what they were being offered, with the presupposition that as agents, they could make a decision. Rather than, because, oftentimes if you say you're a linguist and you work in healthcare, you get some people in the medical field who figure that really what your job is to help them convince people, often ethnic others, to do what they think they should do. As a linguist, that's not my job. My job is to try to figure out where the gaps are, to close those gaps, and to provide people with information that is actionable so that they can make the best decision. But I think that that's not necessarily the same obligation and expectation of someone in healthcare. And of course, those roles are emerging and also being unpacked as we speak, right? Whether or not the job is to convince one of this. And of course, right, I'm going to say the obvious here. The reason why they call it public health is because it is a very concrete example in the pandemic of when the public determines health. So, as we say, I'm from the East Coast, not that that's relevant here, but as we say, a rising tide lifts all boats, but the same goes for a falling tide. So the notion of public health is the very notion that my health depends on yours and your health depends on mine. So is there an expectation and an obligation that's moral and ethical? I think without a doubt there is.
Excellent response. Another question. Based on the idea of privilege, what are your thoughts about mandating vaccinations? Remember, we talked about privilege in the context of health disparities. The mandate, what are your thoughts?
Right, so let's think about it this way. I don't want to be too trite, but in the interest of time, what I'll say is that we have not had I'll give you one example. So I've been at the front lines of this, working with Vanderbilt to develop an app to give people access to actionable information with regard to COVID-19. So one of the things that we've heard consistently is, let's just take a mask mandate for a second here. Been battling with the mayor for some time and others. So in this situation, what we heard oftentimes is that we should not mandate something that we can't enforce. So I'm going to answer the question in a roundabout way. There are cities in the United States that will fine people who drive in these cities and have these incense hanging from their rearview mirror. They're called little car trees. They provide a kind of smell inside of a car. So some cities in the United States have made those illegal, claiming that those obstruct view, okay? They have no problem enforcing that in inner cities. They stop people, right, in multiple states because they have these little things hanging from their rearview mirror. So what we need to realize is that the argument of enforcement and not being able to enforce is a little bit of a red herring. Historically, this country has never had a problem with enforcing mandates or anything else on certain portions of the population. Where bioprivilege comes in is where we recognize the hesitancy, not on the part of the public, but on the part of the government to mandate anything. So part of the issue here has to do with also recognizing that this has to do with who gets to be mandated and who doesn't, who has the privilege and the right to not be mandated, who walks around in a society and feels like they have the right to not be mandated to do anything. So what I like to do in this discussion is to just simply make an apposite, that's with an A, apposite point, which is beside the point, and ask that we look more broadly at the kind of mandates that we as a society have not had a problem enforcing. And then to ask us if we're doing this equitably vis-a-vis COVID-19. And that's not a direct answer, but I think I'm trying to sort of approach it from a perspective that informs it historically, and our unwillingness to mandate some things for some people, and our history of being very comfortable mandating it for others.
Excellent response. Something to think about. Another colleague says, does a big pharma produce vaccines and medicines for purely altruistic reasons? And can financial considerations prevent full disclosure about adverse effects or encourage censorship of other therapies?
It's an excellent question. Of course, it's a different question. It's a difficult question. But what I would say is, to say that something is complicated is not an answer. To say that something is complicated is a description. So my answer to you is that multiple things can be true at the same time. So it can be true that this virus is raging and that it's killing people. And it can also be true that the folks who are producing vaccines have financial interest in producing them, in circulating them, in trying to make sure that as many people as possible are vaccinated. I really think that part of what we need to do as we think through these problems is to recognize that that any response that we give needs to embrace the complexity of the situation. So do I think that what's suggested in the question, that all of that is very much possible? Absolutely. I think we should not underestimate that. But at the same time, when I look at the number of people who are dying as a result of COVID-19 and lack of access, not simply lack of access to vaccines, because in some ways vaccines can become a red herring, lack of access to any of the ancillary treatments that make this disease survivable. So I think what we don't want to do, and I'm going to quote the poet T.S. Eliot, is we don't want to become distracted by distraction from distraction. Multiple things are true at the same time. Yes, it is very likely that they're doing all of that. And at the same time, it is also true that without the vaccination, the death toll continues to rise.
Fantastic. Another colleague says, well, who should bear the ethical burden of leaving people to die when there is a vaccine or treatment available? Whose responsibility is that?
Leaving people to die. And specifically, I would like a little bit of clarification. Do you mean in terms of the healthcare field, or do you mean in terms of the social? I guess I need some clarification for that.
I'll interpret that and not separating the social or the healthcare field, because that becomes a social determinant of health. So let's try to put that in a public health context, either or, both and.
Right. So I think, you know, these are challenging questions, but one of the things that I think we don't do as a result of whatever we decide to become, someone who works in public health or in linguistic anthropology, is that you don't check your culture at the door when you put on a white coat, or in my case, a bow tie, right? You still have your culture. So part of this question has to do with our own cultural expectations of what are, to be frank, what are legitimate ways of dying? What are legitimate ways of mourning? These are deeply seated, deeply embedded cultural ideas that really inform who we are as a people. So I think the question that you ask is a monumental one, right? And I think it's important here to pay attention to the words. And I think you put this very beautifully. But there's a difference between fault and responsibility. While the COVID-19 pandemic and the senseless suffering that we see is happening all over the planet isn't necessarily anyone's fault, it is, because we're involved in humankind, our responsibility.
I have so many questions, but the chat is full of them. So I'm going to.
And Dr. Warren, we also have a hand up that's been up for a moment too.
Okay, I apologize. Let that hand speak.
Ms. Muhammad?
Yes, ma'am. I'm actually, I just got called into an appointment. But goodness, so much has been said. You know, a lot of people are dying and have been dying of diabetes, particularly in the Black community. That's something that is not addressed. A lot of people have been dying of AIDS, HIV. And that is also something that has not been adequately addressed. In my community, people are dying of murder. And in the midst of skyrocketing gun violence, the CDC had passed a mandate that restricted the study of gun violence when our communities, Black communities, suffered disproportionately in that area. So I have a difficult time anyone suggests that maybe it is a distraction to question the motives of pharmaceutical companies who just put 9 new billionaires, you know, in the social culture. You got 9 new billionaires, you know. I guess my thing is this: at the end of the day, right now what we're looking at is violence. We have people operating under different stimuli, so they see the same thing very differently. And it has come to a place of explosion. This question is for Dr. Warren. What is the responsibility of the Bioethics Center of Tuskegee University in this instance, and what should the urgency be? So in other words, don't just acknowledge that this is true and it's a problem. What is the duty, obligation, and responsibility in urgency of the Tuskegee University Bioethics Center? And what does it represent in the context of this whole discussion, the Bioethics Center? Thank you.
Yeah, I appreciate that comment, Mr. Muhammad. I think, to be quite honest, within the context of the coronavirus pandemic, that it has to be taken in context of other issues that are impacting upon our community. Some of them were in the health domain, some of them are beyond the health domain. I think it's our responsibility as the Bioethics Center to pull the appropriate people together to have that conversation and then respond to that accordingly. The appropriate people, by that I mean those who suffer the most and have the most to lose and to gain. So the responsibility is ours, among others, to pull the people together to have the conversation and decide what we should do.
Thank you. I'm gonna be holding everybody to that. I'll talk to you soon.
Absolutely. I can put it in writing, never need to.
Yes, I would like to
Yes, sir.
add to that, if I might. I think the other piece is to recognize that when you think about something like a pandemic and an endemic, right, that these are crises that are defined, right, that these are constructions. And what that means is that as a society, in this case, it's the WHO that decides what's an endemic and what's a pandemic. But I think we need to recognize and how political these crises can be. So more specifically to his point, right? Why aren't those considered endemic, right? Why aren't those considered crises that are worthy of addressing? And we need to realize that that itself is political, but it's not just political, it's also who it's affecting, right? So what we found with the pandemic, I think, is an analogy for what Mr. Muhammad is talking about, because what we found with the pandemic is that as it reached certain shores, right, it elevated its significance. So we need to really think very critically about who gets to determine these labels, right? And what these labels actually mean in terms of access to the ability to research gun violence, right? A recognition of how important this is requires it to actually be legitimized in the eyes, unfortunately, of some.
Another question from a colleague: should Moderna and Pfizer waive their patent rights so that the poorest countries in the world have access to the vaccines?
I was recently reading an interview with Jonas Salk. Not sure if it was true, but allegedly when they asked him about the patent, he responded, can you patent the sun? And the answer, of course, is no, you can't. So should there be an expectation here that this is for humankind? Yes, but to go back to Muhammad's point, we do have to realize that there are forces that are larger here, having to do with thinking about profit margins, and we can talk about the distribution of the vaccine because we've seen inequality in terms of distribution, countries paying into COVAX and not getting their distribution in a timely manner. All of these pieces are significant. But I think this brings it back to Dr. Warren's question about what are the ethics here, right? I think that's an important question.
Are there hands up that I'm missing? I'm staying on the chat. If there are hands up, let them be seen and heard.
I was thinking that the way that the thing is that the vaccine thing is working, to some extent, making a vaccine that is less effective on the short term or that needs boosters is more economically feasible. Because if you need a booster regularly, then you can keep making more money out of it. And I don't like that concept. And I don't think it should be legal, but it would be very hard to prove if it were happening.
That's an ethical framework, a problematic that should be discussed. Yes.
But I wanted to ask you something. When I ask people that have not been vaccinated why they haven't gotten vaccinated, they usually say that they are scared. This vaccine was made too quickly. We don't know side effects, blah, blah, blah. Okay. Particularly, many like to point out that if anything happens to them because of the vaccine, you cannot sue Pfizer and you cannot sue Moderna over it. However, I recently read that even though that is true, there was a fund that was set aside in case that any of that should happen. They could be paid for from that fund without needing to record to a lawsuit. However, I have almost never heard of that being advertised on TV or anything. So even if people have any sort of, like some people have anaphylactic reactions, for example, if some family is affected, they may not know that they can do something. I think it's not fair that people don't seem to have access to this information equally. You have to look it up. What can you tell us about that?
So thanks for the question. So I think to go back to your first question is, it seems to me that not just pharmaceutical companies, but our own NIH and CDC, they've done a really poor example explaining first and foremost how viruses infect us and how vaccines work. I think this is a bit of a black box, but it's not that it cannot be explained. It's important that the general public understand how infection works and how vaccine works. And I think that there has not been any effort to do that, in part, or very little, in part because that speaks to how little, how short they think our attention span is perhaps, or how little they think we know. But I think what that does essentially is that because it is not widely known how viruses infect us and how vaccines work, all kinds of understandings about the development of this very specific vaccine and vaccines in general have been an outgrowth of that vacancy that was explicitly left by the CDC and the NIH. And I think this is really part of the issue. And to sort of put a finer point on this, if you ask people, what does COVID-19 mean? And this is, again, my study as a linguist, what you recognize is that many people don't know what that acronym means. Now, according to the WHO, the reason why they call it the coronavirus is because this is a response to a policy the WHO passed in 2015, where they no longer allow viruses to be named after places, Ebola, West Nile. What they recognized was the stigmatization that was happening as a result of this process, right? So they moved to acronyms, which are less than intelligible. The issue is that COVID-19 is actually the disease name. And the disease name doesn't tell us much about the disease. It's an acronym. So people who study this recognize that one of the ways in which you can be very ineffective in communication is by using acronyms, right? This is widely understood. Yet the WHO does this in response to really what were fundamentally racist names for disease prior to that. So in my work with the federal government, informally, thinking about vaccines and vaccine uptakes, one of the things that I pointed out is that the name itself doesn't tell us anything about the disease, and we don't know how viruses infect our bodies. So what I said is, well, what if we think about the virus name, which the WHO also produces? The virus name is an acronym, but it's also a name: severe acute respiratory syndrome. So what I'd like for you to imagine for a moment is a world without COVID-19, a world where you call the virus actually what it did. Severe acute respiratory syndrome, right, is more than a name, right? It's a description of the disease itself, but that's not the disease name, that's the virus name. So I think so many of these problems go back to really a lack of conviction to try to explain the various aspects of these viruses and these diseases to the public. So I've been waiting for a very straightforward explanation of how viruses work. But my grandfather used to say, if you can't explain it, you don't understand it well enough. Doesn't mean that it's not understood. It means that we don't understand it. So I think part of this has to do with backing up and say, well, wait a minute, maybe if the public are equipped with an idea of how viruses work and how this vaccine works in particular, that might answer some questions.
Last year in Tuskegee University, with a group of students for a class, we made a talk for the people that it was uploaded on YouTube, explaining how viruses work and how the vaccine, how the transmission works and how the prevention works. But YouTube took it down. According to YouTube, it was violating their policies, whatever policy it was, because they are very vague. We had, in fact, two such videos that were like an hour long, and the same happened. So it's like, even some of us are trying to let the people know, and it's been taken down.
I also think, Jatna, and Dr. Harvey, it speaks to the paternalism that's within our system, right? That you should just accept what we say without explanation. And because it is proclaimed by WHO or CDC, that we should just accept. Not necessarily the how, but the what in response.
Infantilizing adults.
Mm-hmm.
There's another question in the chat. It's from a bioethics point of view. What are your thoughts about the state of Alabama using COVID funding to build prisons? That's a reflective question that I think the answer is embedded in the question. I think it is inappropriate and unethical to use funding that is targeted for a disease to continue to build prisons. That's my personal perspective as a public health official.
Is it possible that the prisons in Alabama are overcrowded in a way that if there were an outbreak of COVID in there, they would easily die? But if they manage to build another prison that they can transfer some of, could that be the argument for it?
That is absolutely one of the arguments that's being used.
That's an argument, but that's one that should be debated in a public forum. I think there's some obvious difference of opinion on that. Another question, I don't want to consume too much of the conversation. Dr. Harvey, thanks to Dr. Warren and Dr. Jane for organizing this. I learned a lot from the presentation and questions and contributions. I gotta go, but I think I wanted to say that to let you know, Dr. Harvey, how much this presentation has been engaging, and it's been thorough conversation. So it's really, really important. I'll go to another question, but I wanted to make sure that you got that message from, not from me, but from one of the participants.
Well, thank you very much.
Another question says, the U.S. Public Health Service has not reconciled that they lost the lack of public trust for years. And I think that lack of public trust speaks to a question of trustworthiness. We've written about that. I think you've got to begin to shift the conversation from trust to trustworthiness, because it shifts the responsibility and the authority. I think that was a comment that was targeted to me. But Dr. Harvey, do you have any thoughts about that as well?
I just want to echo your point there. I mean, absolutely shifted to trustworthiness. Also, a recognition that too often trust gets talked about as something that just is, right? Trust isn't just something that exists and it exists always. It has to be maintained. And in the same way that it can be lost, it can be built. So what I think too often happens is we think about it as, well, there was once this thing and now there isn't. If we're thinking about the future and we really believe that human problems have human solutions, we need to sort of focus on building that, but not just building that, but also Dr. Warren articulated, right? Trustworthiness. And how do you create that? And the answer too often has been to find a trustworthy messenger. Well, if I find a trustworthy messenger, that still doesn't make me worthy of trust. I'm using a messenger who is worthy of trust. So there comes a point in time where we need to think about this as a process rather than an event and focus on this project, but not in the moment of a crisis, right? This is something that should be worked on long before this, right? This comes even before the pre-crisis phase. Otherwise, we can't rely on it, right? It's a well that has to be refilled.
Dr. Abdallah has her hand up.
Hi, thank you so much, Dr. Harvey. It's really very excellent presentation. I really enjoyed it. My question, as you see, fully vaccinated people are getting coronavirus. So I remember when the vaccines were developed, they mentioned that they could produce immunity like from maybe between six months until 2 years, but they weren't sure at that time. And I don't know why people are very worried, because as you see with influenza, people that are getting vaccination every year. I don't know, do you agree with me that maybe miscommunications to explain to people that is something could be normal? If you vaccinated, you may get still the virus because the immunity is just finished up till here. You need to get again another shot or booster in order for you to develop or immunity to protect you from getting the coronavirus again.
Right. Yes, thank you for that. And one of the things I think I'd like to point out here, which may or may not be obvious, but part of this also has to do with perceptions of risk. So what we need to recognize, there's another piece of this communicational battle that's been lost, is that the study of psychometrics focuses on risk perception. And one of the things they focus on is the degree to which people are less likely to see something as risky, the more they know it, the more familiar it is. So in this case, the vaccine is so unfamiliar that people are more concerned, I'm using my words very carefully here, about what the vaccine will or will not do than they are about this virus, right? So, and part of that has to do with thinking about the familiarity that people feel like they have with this virus, rather than the familiarity they have with a vaccine that was produced under administration. And I want to use the language here because I think it's important. They call this Operation Warp Speed. So part of what we keep hearing about the rapidity of how quickly this was produced echoes back to what it was called. So I think what it was called is actually having a knock-on effect in terms of certain portions of the population. The other piece is if you just change the name from Operation Warp Speed to Operation Defend America. Now that may sound like a strange thing, but what I'll put to you is that there are people now who are vaccinated who would not be vaccinated if it were called Operation Defend America. And there are people who are not vaccinated now who would be vaccinated if it were called that. So part of this really has to do with perceptions of risk, right? Part of it. And of course, the science itself is not entirely intelligible to the public.
Do you agree with me that right now, maybe at the beginning, maybe that's the issue, but do you agree with me that at this time we have enough data that telling that the vaccine are really working? And maybe again, I think communications to people using the language, simple language people can understand. They hear you, some people they say, or maybe also you explained earlier that they don't explain to them what the coronavirus is. I have seen a lot of videos, they talk about vaccine, but the language is really not easy for them. When they talk about messenger RNA, that's a big word for people, simple people to understand.
Yes, so the issue here is from a scientific perspective, is this working? I think the answer is it's yes, right? The data shows that. However, in this case, right, what you have, again, not unexpectedly, is examples where even today, of course, with the high profile passing of Colin Powell, people using that, any example of a breakthrough as a way of somehow denying the efficacy of the vaccine in general. And I think what we don't want to do necessarily from a communicational standpoint, right, is to try to put out every single fire that emerges, right? There's a recognition that this has not been explained very well. And part of that has to do with an attempt to retain authority, right? So if the CDC wants to retain authority in the NIH, they don't put a lot of ambiguity into their initial statements. But that lack of ambiguity, that lack of a willingness to say, well, things will change, then causes people to engage in whataboutism down the road, right? Which is legitimate. They say, well, what about this? So now people are saying, well, if it works, then how is it possible to die from it? But in some ways, this question is, again, besides the point. It's not, the question isn't really what it seems. It's a legitimate question, and it isn't at the same time. So I don't know if that completely answers your question, but thank you for the question.
I might
Question,
add,
and they can even show them the data, because how many people get vaccinated and how many of them they died. You know, if you see the statistic, it's really not significant because less people died than those that already got vaccinated. So I think how to communicate this information in a way that everyone can understand. I think this is really important, especially in underserved community where they really need a lot of, you know, communication. And thank you so much. Excellent.
other questions, other comments?
Well,
Dr.
the comment that I will add to this is, well, thank you first, Dr. Harvey. Everything is well said, but whether the vaccine works or it doesn't, I think from every indication, there is a signal that this vaccine is working. And what I'm looking at is, as we all know, this is a disease that has already invited or led to a vaccine development as early as it's ought in their consideration in medicine. And so there are many things that are still not known. And to that extent, I want to address what Dr. Harvey said by saying that the name was not properly given to this disease, like possibly SARS. Looking at this disease in the host, how many predilection sites haven't we seen? And so to me, a time to come, we may broaden and then give a name that may address all multiple areas where this virus is found. So to me, I think we are studying this disease within a very possible short time. And so with time, we'll get to know more about it. That is my submission to what you have discussed so far.
Let me assume the privilege of the moderator to say how exciting this conversation has been and to thank Dr. Harvey. We want to end it with many questions left to be answered rather than think we've answered them all. And I'd like to leave the last 2 minutes to Dr. Harvey to give some closing remarks and give us some marching orders how we move forward.
That's a very tall order. I just want to thank you again for the invitation. It's been an honor and a privilege. I think that there are obviously many issues here, right? So for me, the takeaway is a problem as complex as this really requires solutions that reach across disciplinary boundaries, right? They have to reach into all of the very elements of the problem. And what needs to happen in the process is that we don't reduce the problem to a single thing. A recognition that multiplex problems require multiplex approaches, and an unwillingness to kind of throw our hands up in the air. And I don't think any of us are in danger of this, and say, well, there's really nothing to be done. Because what we found is that any absence of clear articulation about what this pandemic is about, or health disparities, right? That absence is always filled by something. So I think part of the thing that this reminds us of is the importance of community engagement. But for me, the other thing is to think about this really as a process, and to think about how much we can do long before the next pandemic reaches our shores, and in terms of anticipating the kinds of risks that people will have, which are not unimaginable, which science can give us. To also think about how this pandemic is also setting us up for and inducing future vulnerabilities for folks who, for example, consider this as nothing more than a cold. On this one, for some, they may have that experience, but if you think about the kind of future vulnerabilities that sets up in terms of expectations, so I think there's a lot of work that can be done, that should be done. And I think these kind of conversations really give us an opportunity to think about all of those who can be involved in this process. And I'm just honored for the little space that I've had here to be able to share a little bit of my work, and to be actually, in a conversation with you all today. I'm very thankful for that.
Before I turn it over to Attorney James, again, I want to thank you, Dr. Harvey, and I hope you all heard a message of one medicine and one health, and that it's taking all of us to pull ourselves together to come up with alternatives. There may not be one solution, but there surely are alternatives. As the science evolves, we've got a responsibility to be sure we share them, what we know, in an authentic and as honest way that we can. Again, thank you, Dr. Harvey. Attorney James, please.
Well, I'd like to thank you both so much for your time and for the engaging conversation that we've had today. I could not have asked for a better way to kick off our afternoon than what we've been able to have with this discourse and engaging our community members and addressing some of the concerns that they have. As we move into this small break and get ready for our afternoon presentation for our students, I'll invite you all to please stay put. We will have our students coming up with Dr. Aduade leading off that section for us. But as we go into the break, and you may need to take a bio break and do what you need to do, I would like to take a little executive privilege, and Dr. Warren, I think you'll enjoy this, and highlight how we at the Department of Graduate Public Health have been working to have our students not only engage across different our institutional boundaries, but move into our communities and actually implement the things that we're teaching in our class to improve the health and access for our community in which we serve.
And it's your creation.
Yes, sir.
Now, I am super proud of every young Black man who has innovation and motivation and inspiration and just want to do something. Well, how did this come about?
Okay, during my time at Tuskegee, while I was studying public health here at Tuskegee University, I took a class called Public Health Ethics. And I took it with a professor named Dr. Warren. And one of our projects was to create a tangible project for the community that supported the health of the community and that practiced good ethics. So what we began to do, we started to do events at the farmers market. So I started off at the farmers market where we was, me and a group of students on campus pretty much created an event at the market to be able to promote fresh fruits and vegetables. So it started at the Macon County Farmers Market from merely wanting to promote fresh fruits and vegetables in Macon County. And from doing that, I was like, wow, we're out here with fruits and vegetables. Why don't we just make smoothies with the fruit and vegetables that the farmers are providing? So that experience showed me that, look, this may be possible to start a business in Tuskegee. So
I just took a leap of faith and said, why don't we open up a smoothie bar right outside of campus? So I started looking around, and then I came across this establishment, and we just pretty much just rolled everything over from the farmer's market to the brick and mortar establishment.
Okay, how did you come up with the name?
So that was like a public health thing too. So during my whole time at Tuskegee University, one of the main things I heard was access. We need access. We need access to fresh fruit. We need access to fitness. We need access to community engagement. So my main emphasis behind the name was access. You know, so whether it was health products, whether it was a social environment, whether it was health products, whether it was health education, this establishment, we want to provide access to health. So that's where the name came from, pretty much.
Where did you get that kind of inspiration from? Who inspired you to be that aggressive, that innovative and creative?
I can honestly say this HBCU culture kind of taught me that. Me coming from Miles College, which is a rival from Tuskegee, I already came to Tuskegee with a chip on my shoulder. So I kind of had to prove myself. I had to show that, you know, I was really invested into this community. So I would say me just being at HBCUs and in the college environment kind of motivated me to continue this in the community, you know, so.
So what do you serve to the people?
So we serve smoothies. Primarily, we serve smoothies and fruit bowls, smoothie bowls. But we also sell health products such as sea moss, CBD, some herbal teas, juices, and the list goes on.
So everything is the capital H health.
Yes, everything is capital H health here. Yes, sir.
Okay. What do you need from the community? Tell the community what you need from them.
Okay, the biggest thing is we need support. You know, being a small business in Tuskegee, that's the main thing we need is support and creativity. So Access Health Bar is open to the entire community. So whether that's the youth or whether that's our seniors in the community, we need that creative recommendations. We need creative ideas to come to the table, and so we can be able to create more events, more activities, more programming. So that's the main thing I promote here, and the team promotes is a healthy social environment. So we just want to promote creativity to the community and a healthy social environment.
And I'm going to tell this community something that you can do. Whenever you are having meetings and other kinds of functions in this community, and you are bringing people in from the outside. When it comes lunchtime, bring those people over here to the Access Health Bar. You know, any group of people on any day can enhance his opportunity to skyrocket. So now that's why we're here today, to show you what this young man is trying to do and to ask you to get behind him and push him and support him so that he can be successful. Now you tell the rest of what you got.
Yes, so I do want to mention this. Every day, Monday through Thursday, we offer happy hour. So just like you have happy hour at all these places in Auburn, we have happy hour here at Access Health Bar, Monday through Thursday from 2 to 4 p.m. And you get $5 smoothies. So the same smoothies that you would get in any other place, we have them here at Access Health Bar Monday through Thursday. So I just wanted to throw that out there. And if you want to reserve our space for any events, summer camps, workshops, anything educational, you have the opportunity to reserve our space as well. So I'm just pretty much leaving an open invitation to everybody in the community to come to Access Health Bar.
And it's not just about smoothies, because I came through here one day and I was really hungry. So I got a sandwich out of there.
There you go.
That was nothing but vegetables and other spices.
Yes.
Now, what kind of sandwich was that?
Yeah, so, and my bad for not mentioning our paninis. Our customers absolutely love our paninis. I think that's one of our fan favorites. But our paninis are made with fresh produce that come directly from the farmer. Mr. Hooks and Mr. Steele provide us, And She's Organic provides us with our bell peppers and our onions and our tomatoes that we put on our sandwiches. And we pretty much have a vegetable panini, an avocado sandwich that you can add chicken, or it can just be strictly veggies on it as well. So we have a combo where you can get a smoothie, a large smoothie like this with the panini for $10. And it is a fan favorite. People are truly enjoying the panini sandwich. Located? Access Health Bar on West Montgomery Road, right here in the Greenwood Plaza, right outside of campus. And our number is 334-421-4124. You can always place a pre-order as well.
Okay, and that's right across the street from the post office.
Right across the street from the post office. Yes, sir.
Okay, very good. Okay.
Thank you so much.
Thank you, sir.
Yes, sir.
And wish you most success.
Yes, sir.
So I just want to take that moment of executive privilege to share that information about one of our students doing great things in the community, and also highlighting the work that you do, Dr. Warren, with us in our ethics course. The students are listening and they are implementing. We appreciate it.
Thank you.
That's great.
So we have about 8 minutes before the next session. And so I'll turn it over to Dr. Adai to lead that section.
Thank you. I'm here. Yes. We are counting our time.